Okay.
Okay, good morning, everybody. Welcome. Thanks for your patience. We're getting a little bit of a late start. I'm sorry about that. I want to let you all know that your mics are turned off and your video, and that's only for security reasons. So if you have any questions, please post them to the group chat. We're going to take all questions at the end of Dr. Bradford's presentation. And this is being recorded, so you can view this. I've posted the link where you can view it in the chat. And I'm just going to very quickly show a CME slide because this is eligible for CME credit today. And one moment, I'm going to show that slide. Takes me always just a second. And y'all, sometimes this doesn't work very well, so I hope that you can see it. But if you are attending for CME credit, please just change your name on your Zoom to your LSU email address. Okay, and I'm going to stop my screen sharing, and I would like to introduce Dr. Tamara Bradford. She is a pediatric cardiologist at Children's Hospital and an associate professor at LSU Health. So welcome, Dr. Bradford. Thanks for joining us.
Thank you for having me. So today I've been invited to just give a brief talk about the SARS-CoV-2 associated multi-system inflammatory syndrome in children that we have been seeing. I have no disclosures. So the COVID-19 pandemic, familiar to everyone, we've been in it for a few months now, has caused worldwide disease since December of 2019 when it was first discovered in the Wuhan province in China. According to Johns Hopkins University, and the link is there have been millions of cases worldwide, hundreds of thousands of deaths, and the US has just gone over 100,000 deaths. 38,000 counting.
Sorry, your screen isn't sharing. We aren't seeing your slides.
Oh.
Sorry about that. That was, yep.
Oh, I think when, yeah, okay.
Yeah. Thank you.
I'm gonna go back. Okay, this is me. I have no disclosures. So again, we talked about that. So the numbers keep going up. Louisiana's had over 38,000 cases with over 2,700 deaths. Initially, and this continues to be the case, children appear to be largely unaffected from the acute viral infection process that a significant number of adults have been dying from. Adult SARS-CoV-2 infection comprised most significantly of severe lung involvement with a high risk of acute respiratory failure, that's well known, and some other organ systems that are significantly affected as well include the cardiovascular system, hematologic, renal, and neurologic systems. Important observation that was made in the adult population is that they typically worsen during the second week of illness, coinciding with declining viral loads and increasing inflammatory response. This inflammatory response in adults was less commonly seen in children with an acute COVID infection, but has now been shown to play a role in this delayed multi-system inflammatory process that we're seeing in kids. So in the largest child case series thus far that we've had just for acute COVID infection, greater than 90% of kids with an acute COVID infection have mild to moderate disease. Children account for only 1 to 5% of diagnosed COVID-19 cases thus far. Of course, the amount of testing also plays a role in that number. But about 5.2% have had severe disease requiring hospitalization, and only about 0.6% have had critical disease requiring ICU. Hospitalization was most common in children less than 1 year of age and those with underlying conditions. But the diagnostic presentation findings are similar, with fever and respiratory symptoms being more common. However, the severe pneumonia and lung disease seen in adults, we have not been seeing in children. Globally, there were very few pediatric deaths from COVID-19. Newborn infants have developed symptomatic COVID-19, but evidence of vertical intrauterine transmission was scarce. And among all US pediatric cases, there was a male predominance, and that is true globally as well. So in late April, or mid to late April, there were reports out of Europe about a small cluster of children presenting with a significant inflammatory response that was temporarily associated with COVID infection or exposure. Cases were also being identified in the New York area, and by the end of April, this disease was emerging as a new entity in association with SARS-CoV-2. In early May, Dr. Jeff Burns, Chief of Pediatric Intensive Care at Boston Children's, hosted a collaborative webinar with pediatric subspecialists in the US and Europe to discuss this new disease we were seeing in children. And at that time, the UK had reported about 25 cases, and the US had about 17 cases reported. Of concern was that all regions demonstrated a high percentage of patients presenting in shock and cardiovascular collapse. The response appeared to be delayed compared to an acute SARS-CoV-2 infection, about 2 to 6 weeks per CDC after initial infection or exposure, as opposed to what we were seeing in adults. By mid-May, it had become clear that a small population of children were having a COVID-associated inflammatory response, but importantly, it was associated with a high incidence of end organ dysfunction, most importantly cardiac, and the findings shared some features with a well-known and well-described childhood disease known as Kawasaki disease that we see in pediatrics quite often. These kids, what we noticed is that their COVID-19 PCR and antibody testing could be positive or negative. Now, whether that depends on timing of testing, sampling variabilities, the current tests are pretty specific for viral RNA for COVID-19, but sensitivity does range. For example, PCR positivity is highest in bronchoalveolar lavage specimens at 93%, but in sputum it's only 72% and nasal swabs 63%. So sampling location and technique is very important. At this time, we haven't yet identified any specific associated or underlying conditions that can be considered high risk. Most kids who presented were previously healthy. However, we really are just starting to define the spectrum of the disease while trying to capture all patients because of the high risk of end organ involvement, which we think is driven by a cytokine storm. So, cytokine storm. This is really hyperinflammation secondary to immune and regulatory mechanisms becoming overwhelmed, leading to a vicious circle of immune hyperactivation resulting in end organ dysfunction and damage. So your immune system is supposed to respond to foreign agents that enter the body. We think that with the development of acquired immunity that's occurring 2 to 4 weeks after initial exposure or infection, the immune response is exaggerated, and this exaggerated response is what leads to the symptoms that we're seeing and the end organ dysfunction that we're seeing. So cytokine storm is a term that has been used probably a lot, especially in the adults, because it describes what has been happening with them when adults have severe respiratory distress associated with COVID and has played a significant role in morbidity and mortality in the adult population. However, that cytokine storm is occurring during the acute infection, whereas in children, what we're seeing is it is a delayed response, likely secondary from the development of acquired immunity, but only in a small subset of kids. So the various clinical manifestations were summarized nicely by Dr. Rimmensberger at the University of Geneva, who described them as vasodilatory shock with normal cardiac function. So basically your heart squeeze is normal, but your blood vessels dilate, which then lowers your blood pressure, compromising cardiac output to your organs. which requires vasoactive medications to get the blood pressure up and maintain stability. Or they can have a septic or cardiogenic shock state with myocardial dysfunction. So here your heart function is not normal, and the principle is the same. Blood flow to your organs are compromised because your heart squeeze is not pumping enough blood to your organs. A third presentation is a Kawasaki-like illness that we are familiar with in the pediatric population that has some cardiac implications, most importantly, dilation of the coronary arteries and in some cases, aneurysms. That becomes important because the similarity between these presentations and Kawasaki disease is the link to how we decided to start treating these patients for this illness. And of course, there are some variations of the above findings that kids can present with. So this is just an example of some of the symptoms that we have been seeing in children. 100% of children have had fever, and in the different organ systems, these are potential ways in which they can present. After fever, GI symptoms were the next most common way in which, or next common organ system that we saw patients present with. The items highlighted in red indicate findings from a clinical standpoint that are similar to what we see in Kawasaki disease and why there is that Kawasaki-like illness reference in regards to this disease process. So based on all this information, the CDC developed and distributed guidelines for identifying potential patients with this disease, which includes pediatric patients less than 21 years of age presenting with fever, having laboratory evidence of inflammation, which I'll show you what that looks like, and evidence of clinically severe illness requiring hospitalization. And then they went on to say that would be having multi-system or greater than 2 organ involvement, so cardiac, renal, respiratory, hematologic, gastrointestinal, dermatologic, or neurological. And no plausible alternative diagnosis, so a patient that has a urinary tract infection or appendicitis is not included. They may have the same or similar presenting findings, but those findings would be secondary to their whatever other viral or bacterial process is going on. In addition to that, they must also have a positive or current recent SARS-CoV-2 infection by PCR, serology, or antigen test, or have COVID-19 exposure within the 4 weeks prior to the onset of symptoms. These symptoms were these guidelines were put out by the CDC, but most institutions across the country developed their own protocols and guidelines for how they were going to identify patients and manage patients. So this is the one study that's most recently been published with this disease process. This is out of France, and this was published in Circulation just on May 17th. So their cohort was 35 patients. Again, all patients presented with fever. GI symptoms were present in 80% of patients. Clinical symptoms were suggestive of Kawasaki-like illness, and we'll describe a little bit of what that Kawasaki is for those that aren't familiar. 80% of patients were in cardiogenic shock and on admission, so that's why this became a concern. This wasn't just kids presenting to the ER with fever and mild symptoms like they do with an acute COVID infection. These patients were presenting very ill, requiring ICU admission in most cases. Most of them had some form of ventricular dysfunction, and coronary dilation was seen in 17% of patients. In this cohort, there were no racial or ethnic differences in the report, but in the UK cohort, they did describe a more prominence of this disease in patients of Afro-Caribbean and Black ethnicity. The majority of these patients were treated with IVIG initially, and 12 of the 35 received steroids. And although 10 of the 35 patients required ECMO, which is the use of the heart-lung bypass machine to help their hemodynamics during the course, they were all able to be weaned off ECMO and they had no deaths. We have not been so fortunate in the US in that in New York, there were a couple of cases with this disease process that did die. So I've mentioned the word Kawasaki a lot already, and this disease is being compared to Kawasaki disease, and this disease has laid the foundation for how we have been managing these patients. So Kawasaki disease was first described in Japan, where the incidence is significantly higher. There, the incidence is about 265 per 100,000 children, less than 5 years of age, whereas in the US, we have about 25 per 100,000 children less than 5 years of age. It is more common in males, similar to MIS-C, more common in the winter and early spring months. Approximately 76% of kids who get Kawasaki disease are less than 5 years of age. What we've been seeing with this new disease process is that most kids are actually older than 5 years of age. The disease, Kawasaki disease, is caused by systemic inflammation of medium-sized arteries. So any medium-sized arteries within the body, but the coronary arteries are the most significantly and most usually affected. This can lead to coronary artery aneurysms, which are the most serious complication and accounts for 5% of acute coronary syndrome in adults less than 40 years of age. We don't yet know the actual cause of Kawasaki disease, but we know that epidemiology, genetics, and environmental factors do play a role. So in terms of the clinical manifestations of Kawasaki disease, you must have a fever for for 5 days or greater, plus 4 out of 5 of the following symptoms. So rash, conjunctivitis, edema, adenopathy, and mucosal involvement. And I'll have a picture of what these look like. And here is just a timeline of when during the course of the illness, these symptoms tend to appear. Most importantly, the coronary artery aneurysms that we get worried about, a coronary disease, we can actually see during the basically 2 to 6 weeks of disease in the subacute phase, not usually in the acute phase. In the acute phase, they may have some inflammation of the myocardium, but not coronary findings usually early on. Patients that don't present with this typical 4 out of 5 can have atypical Kawasaki, and we tend to use laboratory findings or positive echo to help us make the diagnosis. So laboratory findings such as CRP, ESR, those are just markers of inflammation. Other things such as anemia, platelet count of greater than 450,000. So high platelet levels we refer to as thrombocytosis. Low platelet levels we refer to as thrombocytopenia. So albumin less than or equal to 3, so low albumin. ALT is a liver enzyme, so liver enzymes are affected. High white count, and they can have a sterile pyuria with where the urine, there's not an infection in the urine, but we do see white cells. So when I talk about the clinical manifestations or the symptoms that patients present with fever, so here's a rash that might look like what the kids would present with. The conjunctivitis is non-purulent and non-exudative. It is just red eyes, strawberry tongue, a very red tongue, dry, cracked lips, edema, redness of the hands and feet, swollen lymph node, usually one-sided. This is just angiography showing that other medium-sized arteries within the body can be affected, but usually it's the coronary arteries that can have aneurysms or be dilated. And coronary arteries, I'm a cardiologist, I have to show you what that looks like on echo, just one slide. Here, this is normal. This is the aortic valve, which is the big great vessel coming off of the left pumping chamber. And when we look at it on ultrasound, we see the left coronary artery here and the right coronary artery here. So just stay with me, just pay attention to the sizes. So this is what normal should look like. And if you can tell, you can see that there is some dilation of this left coronary artery here, and even further significant dilation of this left coronary artery here. And here is where what we would call giant coronary aneurysms. These are just very significantly elevated. And of course, this comes with an increased risk of coronary syndromes, myocardial infarction, and even death in some cases. So in terms of the laboratory findings, we've already looked at this data in Kawasaki disease. So the similarities in MIS-C include anemia, low albumin, elevated C-reactive protein, elevated ESR. Again, these are markers of inflammation. They're non-specific, but we would see them increased in diseases such as this and bacterial infections, etc. AST and ALT are also elevated, and these are liver enzymes. Other labs on this graph, BNP, troponins, ferritin, fibrinogen, D-dimer, we don't tend to obtain in Kawasaki disease, but these are also abnormalities that we see in MIS-C. So if we then look at this graph or these charts and pick out the things that are different, the platelet count is high in Kawasaki, but it's actually, patients in MIS-C are actually thrombocytopenic, so they have low platelets. The white count is elevated. The white counts in MIS-C can be the same or elevated or low, but they have significantly decreased lymphocytes, which is a specific type of white blood cells. So important findings thus far. So male predominance, that was seen in all cohorts, and that's actually consistent with Kawasaki disease. Older age kids in MIS-C, more in the range of 5 to 15 years, as opposed to Kawasaki disease, usually being in kids less than 5 years old. Race, we haven't distinguished or determined yet specific differences in terms of published data, but I know that the UK cohort did reference a predominance in Afro-Caribbean and Black ethnicities. So those are still things that with ongoing longitudinal studies that we'll be able to figure out. I will say that in the patients that presented here at Shinola with these symptoms, we had a high incidence of Hispanic patients in our population. Interestingly, there are also geographic differences because as of early May, there actually weren't any reports of such presentations of MIS-C in children in Asia. And that again will be something that needs to be looked at in the future with ongoing research. In terms of severity of disease, the profound hemodynamic collapse and shock states that these patients presented with, we just don't tend to see that in Kawasaki. Only about 5% of the kids with Kawasaki disease would present with cardiovascular collapse and hypotension requiring vasoactive agents. So this disease is definitely more severe. And based on what we see in the French cohort, there's definitely a higher incidence of coronary abnormalities, and they're actually happening sooner. Cardiac involvement is sooner with increased severity. So myocarditis, although we do see that with Kawasaki disease, the ventricular dysfunction that we're seeing in MIS-C is just not a usual presentation for Kawasaki disease. And the coronary anomalies, again, as I mentioned, 17% in the French cohort, whereas in Kawasaki disease, if kids are treated appropriately with IVIG within the first 10 days of illness, the incidence of coronary abnormalities actually goes down to about 3 or 4%. In terms of clinical symptoms, GI, very common in MIS-C. and neurologic symptoms are more common as well. However, in Kawasaki disease, although they might have some irritability, fever and those other symptoms that I showed you in the pictures are usually how they present. And the lab changes, as I described, are more profound. There may be some similarities, but even in those labs that are similar, the levels are just astronomically higher in MIS-C than Kawasaki disease. So treatment, so I talked about the fact that we used the similarity between this disease and Kawasaki to lay the foundation for how we're going to treat these patients. So in Kawasaki disease, based on the AHA guidelines, IVIG and high-dose aspirin are the standard of care. So IVIG is an infusion of pooled immunoglobulins, or just think of it of antibodies from plasma of approximately hundreds of or more blood donors. So when you donate blood, they separate the plasma, and within that plasma is where our antibodies are located. So they pool those together, and that's what we use for treatment in multiple disease processes like Kawasaki disease. And high-dose aspirin. High-dose aspirin for its anti-inflammatory effects and also for its anti-thrombotic effects. Because if you can imagine, within the coronary arteries, when they get injured with dilation or aneurysms, there is endothelial damage, and we think that there's an increased risk of thrombus and clots in those locations. It's kind of the same thinking and phenomenon where you would see like adult cardiologists putting adult patients who had MIs or are at risk for an MI on aspirin. Inotropes and management of cardiac dysfunction in patients that are in shock. Corticosteroids, the holy grail of anti-inflammatory medications, that's also been used in a subset of patients. Immune modulators and antivirals, there's not a lot of data, of course, for anything that we're doing right now for COVID-19, but some IL-1 and IL-6 inhibitors have been used in a small subset of patients in addition to remdesivir and ritonavir. However, these are used in conjunction with consultants when these patients get admitted. So just some future directions. Our cohort here was actually submitted as part of a larger US cohort of about 210 patients that were submitted to the New England Journal. However, it's not been accepted yet, so I couldn't really talk about any of that data from a US cohort standpoint and what we've seen. Obviously, there are going to be more longitudinal studies looking at COVID-19 in children and this associated inflammatory process. We need to further delineate the disease, identify whether there are kids that are at higher risk, potential environmental factors, treatment options, etc. And then the impact of a potential vaccine. If this disease is associated with developing acquired immunity, is that going to be a problem when we get to the point of being able to administer a vaccine, because that's what vaccines do, help us to acquire immunity for diseases. That's all I have today. Thank you.
All right, thank you so much, Dr. Bradford. That was really great. Oh, I have my video muted. I do want to, y'all can please post your questions. I see they're already coming in the chat feature. It should be at the bottom right hand of your screen, and we will start reading those now. We have a question. MIS-C is low platelets, but more common coronary abnormality. 17% MIS-C versus 4% KD in French studies so far. Would aspirin even help?
Yes, aspirin will definitely help. I think what we've noticed with all of the lab abnormalities and knowing the process and the history of Kawasaki disease, aspirin, depending on how sick the patient is, because in some patients, if your platelets are less than 50,000, we may not want to use aspirin in that setting. But for patients that have platelet levels that can take aspirin, we would, in conjunction with hematology, discuss the ability to use aspirin in most patients. And then when these patients start getting better, initially they might be in a situation where they can't be started on aspirin, but as they get better in the course, then aspirin can be introduced at a later date and continued for an extended number of weeks, just because we think there's also a thrombotic process associated with this disease. And we don't know, we don't have any long-term or longitudinal data to let us know whether or not this is helpful or harmful. We're using the information that we have from other disease processes to help figure out what's going to work with these kids. But the impact on the coronary arteries definitely suggest that aspirin would be helpful, maybe not in an acutely hemodynamically patient that's sick, but definitely as they get better and for some period of time after they get discharged from the hospital and in conjunction with follow-up from cardiology.
Okay. I think following up the same, why not use Plavix or antiplatelet agents?
A great question. So in the pediatric population, unfortunately, we are less familiar with those drugs that are used tend to be used more in the adult population. Now, I will say in Kawasaki disease, there is an anticoagulation protocol. If you have severe dilation or aneurysms, we actually can't use just aspirin because of the higher risk of clot with the more severe disease we see in the coronary arteries. So there is a protocol where Plavix can be used and other types of medications that are more common in the adult population. Most Kawasaki kids, though, do well with aspirin, and if they don't have significant coronary disease, we don't need to escalate the anticoagulation therapy. But a lot of the use in just general pediatrics has to do with the familiarity of just using aspirin and the fact that most kids do well without increase in severity, so they don't need to escalate to other forms of anticoagulation.
Okay. In other cytokine storms like HLH and MAS, and to a lesser extent Katie, elevated ferritin is a hallmark of the disease. Since MIS-C is a cytokine storm, should we routinely look at ferritin? Do you know what is that? Am I saying it right? F-E-R-R?
Yes.
Okay.
Yes. So ferritin is a lab marker of inflammation, I think. Okay. I go back here, and it is one of the labs that we do check, and it is elevated in this disease process. Yes, and that is true. HLH and MAS it's all an umbrella of cytokine storm phenomena. And so that's why these particular labs are what we tend to obtain. There are actually secondary labs that include lymphocyte subpopulations where if we consult an immunologist, they might help us with obtaining those labs, because if a patient's not doing well and we need to look at immune modulators like anakinra or tocilizumab, then those secondary types of labs will be obtained in regards to helping to manage the patient, depending on where they are and how sick they are.
Okay. Something that you mentioned that I just wanted to go back to see if you could expound on it was the you said the development of immunity seems to be a factor in MIS-C. Could you talk about that a little bit more?
Yeah, so we're not really sure, but what we know is that the timeline is, if you look at when the cases started to ramp up in the US and in Europe, February and really March, you look at that line and there is an increase in that over time. These cases started about 2 to 4 weeks after that. So we think that this delay that we saw in these kids is not secondary to an acute COVID infection, but they've already been exposed, they've already gotten the infection, and they were not sick. As I mentioned before, kids usually have mild to moderate disease. However, 2 to 4 weeks after that, when the body would naturally be developing acquired immunity to this virus, is when we see the subset of patients pop up. And so that's why I say that we are hypothesizing that this process has to do with the development of acquired immunity as opposed to the initial acute infection with COVID-19.
Okay, got it. And so is that common?
There are some disease processes that are like that. They tend to be rare. I think Mike Levin from Imperial College in London mentioned that dengue fever is something that presents like that. And like someone asked a question about, this is not secondary to a virus, but HLH, which is a disease process that is familiar in kids, and MAS, those are syndromes that we're familiar with and that we know that the impact on the body is the same. We know that it is from an exaggeration of an immune response that causes this hyperinflammation, and this hyperinflammation then causes damage to the tissues. When your immune system is responding to something that's foreign, there are a lot of regulatory mechanisms that occur and result in a lot of chemokines and hormones that are released. And if that response is too much, it can actually cause damage to tissues. And that's what we hypothesize is going on based on all the information that we have so far. Looking at this longitudinally, though, as we learn more about the virus, I'm sure we'll get more information and hopefully more specific information about the cause behind it.
Right, okay. We do have one more question. So if you all have any more questions, please post them. We're gonna wrap up in just a couple minutes. So this question says, could a hyperechogenic coronaries on echo without dilation be a sign of coronary vasculitis?
Yes. So when we look at the coronaries on echocardiogram, any abnormalities that we see, so it could be ectasias, which could cause that echogenic findings, can be concerning, where we would use that as a basis. And the reason that we would is because if we treat it as not, then the potential for that kid to go home and have progression of that coronary disease is something that we want to prevent. So we would treat that kid as a positive, and so that way they get the appropriate follow-up with cardiology and from a medication standpoint to make sure that we limit their risk of progression of this disease. Until we know more. And a lot of this it's emerging, so we don't quite know. And we want to capture as many patients as possible, because the worst thing that can happen is we not identify a patient, they go on to go home, and over the next several weeks develop significant coronary disease and have some type of life-threatening event or something like that. So right now we're trying to have a wide catch net so that we don't leave any patients at risk for long-term problems.
Mm-hmm. And I know you can't answer specifically about numbers, but are we seeing a lot of cases in New Orleans?
I would say no. The population that we're seeing, the numbers are still small. Based on if we look at the best case scenarios, if I can draw out a trace of when the cases started to rise and peak, and then when we started to see this start to present. So as our numbers plateau and start falling off, I would think that the risk or the likelihood of us starting to see this go down is also possible. But COVID has not been eradicated, it is still there. So we might have peaked, but there may continue to be ongoing cases as we continue to deal with this virus over the next several months to years, potentially.
Right. And one more question. So overall treat MIS-C like KD, like Kawasaki disease?
Or most patients now, some programs are a steroid first program. We have used IVIG here, and we actually use both IVIG and steroids. I didn't want to inundate the crowd with our particular guidelines and protocols, But here we decided to use a combination of IVIG and steroids and aspirin at different doses depending on how severe the presentation was. Other institutions, most other institutions, I've been in touch with Texas Children's, Boston Children's, Yale, Columbia, Montefiore, Imperial College in London, so many other institutions, and looking at their protocols and guidelines, it's similar. One or two programs start with steroids first because of the anti-inflammatory effect, but it's usually some combination of IVIG, aspirin, especially if they have more of a Kawasaki-like presentation as opposed to a shock presentation.
Okay. Okay, so we're going to wrap up now. Thank you, Dr. Bradford. That was really interesting. Thank you so much. Just a couple of housekeeping notes. We're going to continue hosting these webinars. We have 2 scheduled for next week. I've posted the website to our chat where you can see the recording of today's webinar. It will be on our website at lsuhealthfoundation.org/coronavirus. You can see that there. It takes a couple hours to show up. You can sign up for next week's webinars at a site I also posted. And next Tuesday, we have anesthesia providers adapting to changing roles during the pandemic. So that will be an interesting one. That'll be next Tuesday at 11. Thank you all for joining, and thank you again, Dr. Bradford.
Thank you.
All right, take care, everyone.